Yeah, we'll assume that people were hard pressed to leave the hall, and doesn't talk about my popularity. Okay. Now it's my pleasure to invite my co-moderator for this session, Dr. Chaitanya Mudgal. He's been a great supporter of education for Indian Hand Society. Welcome, Chaitanya. And I would invite the panelists for this session, Dr. Jin Lim from Singapore. Would you take the chair on the stage, please? And Dr. Lee Moon E. Tina, Dr. Kiran Ladkat, Dr. Ravi Bhardwaj, aka Osteoblast. And one more panelist, Dr. Srinivas Rajappa, a senior hand surgeon from Chennai. He will join us. He's busy in the session downstairs. So Chaitanya, you want to say something before we start the session?
Yeah.
Yep.
Well, it always speaks volumes about the session when the number of moderators and panelists is higher than the number of audience. It's always humbling when that happens. But we're going to have some fun. So the idea behind this session is, as you're going to see, that Pankaj and I have put together some cases. And the idea is just to have free-form discussion. There's followed by a couple of illustrative cases from my archives with some data to support it. So with that being said, I'll hand it over to Pankaj.
So our first case that we discussed today is a 31-year-old gentleman, a manual laborer, came with injury to the non-dominant hand, and these are the best X-rays that we had, trauma X-rays. Ravida, your opinion on X-rays, please.
Yes, 31-year-old non-dominant. It's obviously, given the nature of the fracture, it's an intra-articular injury. You can see both columns involved. You can see the radial styloids fractured. You can see the intermediate column also. There's a depression of the articular surface. It seems to be a die punch component, and there's a vertical split which is heading up the shaft proximally. So, and also I'm not very sure what's happening in the dorsal ulnar corner probably, so, and there's a styloid fracture as well. So taking everything into account, this is something which is probably involving all the three columns, yeah? And maybe my next thing would be to get a CT scan for more information before I decide how to tackle this.
Okay. Dr. Tina, as Dr. Ravi was describing this, are you formulating any treatment strategy for this gentleman?
Hi. Sorry, the question was because we were distracted by the microphone.
Looking at the X-ray, do you have a tentative plan for treatment for this patient?
Yes. Just by the X-ray alone, we can tell that this is AOC3 type of distal radius fracture with severe articular comminution. So our main aim will be to restore as much as possible the articular congruity of the distal radius. And then after that, my side consideration would be whether or not to fix the ulnar styloid. So as for surgical considerations, it depends on what we are all familiar with. It can be done arthroscopic assisted, but I think doing a pure open reduction and internal fixation is fine as well. So personally, how I would approach this would be to approach it, of course, I'll get a CT scan first if possible. If not, then I'll get at least a joint view, the 22-degree joint view, to see whether the dorsal as well as the volar surfaces are affected as well. I would prepare the need to use a bone graft. Usually I take the olecranon, bone graft from the olecranon, especially in a young patient like this gentleman. If the patient is elderly, then in my center, we tend to use artificial bone grafts. Yeah. Mm-hmm. Next step, I would do a standard volar approach, modified Henry's approach. Do I continue and talking?
Got you. Okay. So
we can go on forever.
So I'll come back to you.
Okay.
Kiran, does that styloid tell you something? I mean, would you be prepared with a styloid fixation, or you probably think this won't need it?
No, CT scan will give me further information about the radial styloid. The
Uh,
radial styloid you are mentioning
ulnar
about the
styloid,
ulnar
ulnar
styloid.
styloid, ulnar styloid. It
Ulnar
looks like
styloid,
it looks like a foveal foveal
it looks
injury.
like through the base at the fovea, but it's still undisplaced even on this view, even before the reduction and the radial alignment getting restored. So that gives me some confidence that ulnar styloid may not require any treatment. On radius alignment restoration, based on that, I'll get the intraoperative assessment of the distal radial ulnar joint, and then I'll decide about the ulnar styloid fixation.
Yeah, just get up and point on this.
My concern is, you said you would go volarly. My concern is this and this. So you have a split here. So this is dorsal.
Okay, I will put that to rest. This is what you have.
Yeah. So you see the amount of intraarticular, the depression, the step here, and this is dorsal. So most of the time, and this is volar cortex here. So I would go dorsal and probably, let's have another view, and then maybe go. Okay. So for these, I would go dorsal, open it up, just flip it up like we would do in a tibial plateau, elevate the joint surface, whether or not we add bone graft, artificial, or it's subject to how much of the void. It's a young patient. But then this is where the problem is, the dorsal ulnar corner. If you approach it volarly and you're hoping to sort of engage that, this sort of thin sliver of bone with this kind of intraarticular depression, this calls for some sort of a buttress fixation. It's not going to be amenable to a screw which is going to be, bicortical. If you're using locking screws, you could use rafting screws to, from the volar side, if you're putting a volar plate, to put them subchondrally to raft the articular surface. But this fragment here, this is where my concern is. And I would go nicely, this is a thin shell, just flip it open, elevate the articular surface, reconstruct that, put a graft or whatever, put a plate, buttress this, go on the ulnar styloid. This will also sort of call for a radial, on the radial styloid, put a plate on the lateral side. So it's an orthogonal fixation. It's two plates, dorsal and radial, and that would give me the kind of fixation which I would be happy with. I would then proceed to evaluate the DRUJ stability and then fix it if I want. In my inventory, I always have a complete set of whatever you could probably need in a distal radius fracture, plus the small fragment set to bail you out.
You're talking about multiple plates here, aren't you?
Fragment specific.
Okay. Could you have achieved that through volar approach, Tina?
Before we go to management,
Sure.
I think there's a few features of the radiographs and CT scan which should give us pause for concern. And one of those is the exit of the fracture line on the scapholunate crest of the distal radius. And when you have that in the back of my mind when I'm consenting the patient, I will always talk about the possibility of an occult scapholunate injury. So the next question I have for any of you, since Tina mentioned the use of an arthroscopy, would you foresee the use of a preoperative MR on this person? Or you're comfortable needing utilizing a scope if you need it at the time? If you're comfortable with that, then you don't need a pre-op MR. But you would probably need to have that discussion with the patient, especially given the fracture geometry.
Any other thoughts? Anybody wants to differ from what Ravi is saying? Yeah, go ahead.
Myself. Hi, that's a
Hi.
great idea. I think this can be approached both ways, both volar and dorsal, or a sandwich plating. So I would probably still attempt to approach it from volar, and then I'll use rafting screws, as you mentioned earlier. And then if need be, then the dorsal ulnar cortex we open and put a small fragment-specific plate there, just one single columnar plate for the dorsal fragment to reduce the implant presence on the dorsal surface of the distal radius.
So when you approach that volar, how would you consider elevating the articular depressed fragments? Would you make a window, or you would elevate them dorsally and then plate from volar side?
No, so I'll make a window and then go through the fracture site on the volar aspect, the window from the volar aspect, and then use any instrument.
Okay.
My concern is if you look at
Periosteal elevator, yeah.
If you look at it here, this one and this one is 3D obviously doesn't give us the complete picture, but here
Yes.
that seems to be almost an intact volar cortex
Yes.
get to the dorsal comminution, which is here, and then that leaves us only a very thin sort of fragment of bone. So in my mind, even if we went volar, I would take your idea. I would put a small mini buttress plate, whatever, from the dorsal side, even if you didn't want to open it formally. But that fragment is begging for attention, and that might come back to bite you. Like I always say, it's not about what you can get away with, but it's always about what comes back to bite you. So belts and suspenders for me, whenever I have the
Perfect.
opportunity. Yes.
Yep.
Mike, there it is. Since both of you have such contrarian views, I felt it essential that I introduce you to this. Okay. That was my attempt at levity. For those of you uninitiated, that's Eye of the Tiger from.
I come in peace.
Get a
So-
set of boxing gloves too.
So this is what the index surgeon did. Who wants to criticize this? No, you later.
Sorry.
Yeah. Dr. Jinji.
Yes. Okay, so actually I would do what Tina has said just now. I would go from volar. Okay, but just criticizing this fixation. I think it's not clear from the X-ray whether the articular steps were reduced, first and foremost. But I do see attempts of putting in bone graft to elevate the articular fragments, and that is what I would do as well.
Jinshi, there's an old
Yes.
principle in periarticular orthopedic surgery. Put in so much hardware that you can't see a darn thing.
Yes. Yeah, it's actually very hard to comment on the reduction, but the overall shape looks intact. But I do notice there's nothing done for the ulnar styloid, and maybe there's a little widened scapholunate interval. So to answer your question just now, I would usually put in a scope for this kind of cases just to check.
Okay, so you put in the scope, and then you realize your reduction is imperfect. Are you going to take it all apart and do it all over again?
It depends. So Tina said she would take it all apart. But sometimes when it's so comminuted, taking it all apart will make it worse.
Yes.
Because after that, you may not have anything else to drill. But if there's one or two articular fragment that is obviously depressed, you can use the scope to elevate it. Yeah, but I wouldn't take it all apart.
Yeah, and I mean, I hear you, and I'm just wondering, if you were to put the scope in, does the location of the articular incongruity influence your decision to take apart or not? If it's in a non-weight bearing zone, do you care if it's incongruous? No. But if it's in a large part of the articular surface, which is in contact with the scaphoid or the lunate fossa, then yes, then I can understand why Tina would be so enthusiastic.
Yes. I also recently had a case where I put in a scope for something that is comminuted. And in that case, there was some gap that I saw, but I decided I can't do anything better.
Yeah.
But I think about a year later, the patient had some symptoms, so I put in a scope again. She had a lot of stiffness. And when during the arthroscopic evaluation, actually the articular surface healed really well. So I think some gaps, maybe 2 mm gap, there's no problem at all.
You say gap or step?
Gap.
Gap.
Okay. Yeah, the index surgeon did not do arthroscopy. He did not know how to do arthroscopy at that time. Ravi?
So
Yeah.
my concern about this fixation, I mean, taking all into account, I'm giving the benefit of the doubt. The surgeon must have done a good job with the articular reconstruction, although we can't see it very well. So if we've got bone graft in here, and he's used the plates in purely a buttress mode, there are no raft screws. You see, all these are sort of vacant. I know there seems to be one screw there, but I wasn't surprised that, you see the kind of depression we had on the pre-op CTs. So that's one huge segment of intra-articular depression which is begging to be rafted, and that has been ignored. Secondly, you see that initial X-ray, there was a linear split, and you put screws from an anteroposterior direction, or from dorsal to volar, the dorsal plates, and then there's a split. You don't know whether the relation of the splits. The problem is the conventional plates don't give you that length to tackle, with a volar plate, you would have an option of a longer plate, with a locking, like a variable angle on the volar side, but it doesn't have any manufacturer, to the best of my knowledge, doesn't have a dorsal plate of that kind of length to tackle that kind of situation. So that is something which we should bear in mind. The linear split is something.
Kiran, you had
And
something to say?
all the
Sorry.
3 plates also ending at the same level.
Okay.
I wouldn't be happy with that.
Okay.
How far are these X-rays taken? As in, I can see ulnar styloid healed on this X-ray. So that's a follow-up X-ray?
Yeah, that's the second one is a
Subsequently?
follow-up X-ray.
Okay.
The one on the right is about maybe 3 months.
With the first X-ray on the left, I would be concerning about this cortical screw coming from the styloid plate that was possibly going down to the fracture and the sigmoid notch. Now with this X-ray on the follow-up, the fracture healing well, you're safe, but that could have been one of the concerns. Otherwise, I agree with dorsal approach.
Okay. Want to say something, Chaitanya?
Well, I don't know that I'm unduly concerned about the longitudinal split, because no matter what you do in the fracture of this nature, I don't think I would be comfortable getting the patient to rehab early anyway, given the degree of articular depression. So I'm going to keep him quiet for about 4 weeks. So even if I don't have plates of adequate length, I'm totally comfortable as long as I get my joint restored. And if I'm really, really concerned about it, all I do is take another 2.7 plate and plonk it on this plate, and I do stack plating. It works just fine.
I mean, that's what I would have done.
Yeah.
Like I said.
So a couple of years down the
In that
line,
case-
this is what was done.
Yes,
The implant
Kiran.
was taken off.
In that case, the
Kiran,
question is,
Sorry?
if
Yeah.
you have elevated the fracture surface and you haven't drafted it for a subchondral buttress, how much will you immobilize? Only for 4 to 6 weeks is enough?
I don't think, so elevation without something to support it is impractical, if not illogical. If you elevate, you got to support, right? Whether you support it with hardware or you support it with graft
Bone
or
graft.
both
Right.
is essential. I don't think in this circumstance, I would just pick it up and just put something on the top. Won't work.
Yeah. So this was the eventual outcome. I think this was a couple of years down the line. Yeah, points taken on a lot of aspects. One, importance of arthroscopy and perhaps more number of raft screws. And as Kiran pointed out earlier, the styloid, since it had retained its place right at the site of trauma as well, so perhaps the TFCC was not under too much stress, so and it went on to heal well. Yes, a lot of hardware couldn't make out what was done radiologically post-op. Dr. Chaitanya will take us through a few of his cases and some of his published work on this. If any of the audience has any questions.
Yeah. This is free form. Just keep coming.
So, in regards to the raft screw, are they easier to put from the volar side or dorsal side?
It's always easier to put from the volar side with the variable angle feature, and you have more plates. The dorsal plate, even I'm not very happy even with the variable angle feature. They are much more thinner and low profile because they are meant to sit on the dorsal aspect of the radius. You don't get that many options in terms of the angle and the trajectory with dorsal plates, at least the ones which we have available in our inventory. So to answer your question, sorry. I think I'm audible. So to answer your question, technically it's always easier to put it from the volar side, but obviously it has to be dictated by the fracture pattern you're dealing with. You cannot go in with a fixed approach that I'm going to go volar in all cases or dorsal, so the idea is to be flexible. Yes, there's an emerging trend. I think Dr. Chaitanya will correct me if I'm wrong. You can get away in a lot of cases by judicious use of a volar plate. So that has eliminated a lot of dorsal plating which used to happen. So my own incidence of dorsal plating has come down. But there are certain definitive indications where, I won't shy away from going dorsal if I need to.
Thank you.
Just opinion, because patient is already having radial styloid fracture. Can we go through that fracture? Because anyway we have to reconstruct the radial styloid, and from there you elevate the depressed fragment, and simultaneously can be fixed styloid and depressed fracture.
Yeah, you're saying through which approach?
Yeah.
You're saying just ignore everything else, just go to the styloid directly.
Yeah.
So that would probably mean going through a volar approach.
Yes.
Is that right? Is that what you're visualizing?
Not to volar.
He's mentioning only radial approach. Through the radial styloid, elevate the articular fragment.
I'm not sure only buttressing the radial styloid fragment would alone be sufficient for this person. You need a dorsal buttress to hold the elevated fragments in place.
Yeah.
Okay, so I'm not sure only dealing with the styloid buttress is a good idea here.
No. What I'm saying that through the same approach we can elevate because it is also towards radial side.
Your point being, there's no need to go dorsal. Is that what you're trying to say?
Yeah, I'm
Okay.
just assuming.
Yeah, point taken. Yes, instead of making a window, you could go through the fracture. Is the what he's saying?
So, may I sort of get your thoughts? Sorry, it's okay to have a.
Oh yes. Okay.
So, may I get your thoughts on Peter Brink's paper about the key corner concept? So, if you look at that paper, they say the intermediate column there's a dorsal, and and the fractures always happen in fixed permutation and combination. So, my concern here is if you look at the intermediate column, the dorsal part, you see the amount of, and you see the lunate also tilting that way. So, the key corner, and that usually doesn't have any, you could push an unstable column and keep it that way, or you could have a very tentative fixation with a screw from the volar side. I would sleep better if I had a dorsal buttress plate in place. Size of the plate, it doesn't have to be a massive one, but enough to do the job. But my concern would be, I would be happier buttressing that, and also, you see this part, if it's not buttressed here properly, this would lead to sigmoid, incongruity and later DRUJ arthritis, and at some point of time you will have restriction pronation sequence if you follow them up long enough.
I'm just trying to get back, yeah. So, it's good that we have this thought process, but about where to get to this fracture from. I'm always reminded of a story of a bank robber called Willie Sutton in the United States. Willie Sutton was asked, "Why do you rob banks?" And his response was very simple. He said, "That's where the money is." And so let's presume we all are Willie Sutton, and let's presume this is the bank. Where is the money? The money's on the top. The feature of this particular fracture is this. So this is something that we wrote when not to use a volar locking plate. And this fracture is what we published as the scaphoid impression fracture. The previous description of this fracture was a case report from the late 80s. And based on this, there are two types. So what you see is there's a radial styloid fragment, which we saw. There's a dorsal cortical break, which we saw, and articular depression of varying degrees, but there's almost no involvement of the volar cortex. So if you were Willie Sutton and this was the bank, the money's sitting on the top. So that's where I would go. And then you end up with two types. There's the type 1, which occurs with the corpus and radial deviation, giving you this larger, very large depression, which is similar to the case that we just saw. And the other one occurs in ulnar deviation. So this is how, and you don't need fancy plates, by the way. The humble K-wire, which costs you $5, works just fine. Now in this case that you see, the volar cortex is undisturbed, the depression is central, and which is why I raised the concept of arthroscopy. Yes, if you're a facile arthroscopist, arthroscopically assisted would be a perfectly reasonable thing to do for something like this. And the second one, the type 2, is one that occurs in ulnar deviation, where the proximal pole of the scaphoid makes an impression. That's why they are called scaphoid impression fractures. Again, the volar cortex is completely undisturbed. So that's the reason to go dorsally. And usually you exploit, as Amit said, you exploit the fracture. So you open it as a trap door, you elevate, you graft, and then you fix with whichever method you want. So, all right, so that's that. Yeah. Before we move on to the next case, if there's any more duking out to be done, happy to take any more questions.
So you saw almost identical cases managed with a lot of hardware and very minimal hardware. As long as we got to what we were set out to do, that is to elevate the articular surface and make sure it was well supported. Yes,
Just
Kiran.
one point. How long do you keep those K-wires? And next case we saw a screw with a washer.
Yeah.
So that adds one more hole using a washer, right? Or
No.
one whole plate.
Yeah, so I always tell my residents to think of a washer as a one-hole plate. That's number one. Number two is if you're using K-wires, I usually use them for 6 weeks. Because remember, yesterday I pointed out that we did a randomized prospective trial where we looked at patients who had the distal radius fractures fixed internally after open reduction and were mobilized within 5 days, and those that were kept quiet for 4 to 6 weeks. At the end of 6 months, provided the fractures were similar, outcomes were the same. So it really doesn't matter. The other corollary I have is small fragments equal small implants. More implants doesn't mean clever outcome.
Perfect. That's the message.
Yeah, this was a 23-year-old male, semi-skilled worker, had a fall from height. He had injury to both wrists, but we just discussed the one side. So this was his X-ray. Who wants to take this?
Okay. So this is a young patient with a high energy injury, and actually the injury is more than a distal radius fracture. It's a radial carpal fracture dislocation. So what I would do with this patient is first do a preliminary reduction and then followed by a CT scan. The surgical principles involve restoring the radial styloid fracture and then pinning and repairing of the ligaments of the radial carpal joint.
Okay. Any other viewpoint?
Agree.
Okay. Chaitanya, you want to say something on this? Because the index surgeon did none of what Tina said. Sorry, Jinsi, sorry. Yep. So this is what the index surgeon did. So again, I use the same trick. The index surgeon used the same trick. Lot of plates, so you don't see what's happening inside. So this was operated as an emergency. So
Tina's chuckling there. Tina, don't chuckle.
I'm not. I smile often.
We are wondering what the plates are holding.
okay. Yeah, go ahead. Yeah.
Oh no, I'm really wondering what the volar plate was for.
Okay.
Can we go back to the original X-ray
Sure.
again, please? Yeah, see, right, it doesn't look like there's any volar rim involvement. It was
Okay.
probably just purely ligamentous there, so I'm
Okay.
really wondering what the volar plate was.
Yeah. So can we just put that question on on the shelf for a moment?
Okay.
We'll come back to that question when we see maybe the third or the fourth case. Yeah. What was the volar plate doing? Okay.
Can I ask?
Yeah. Go ahead, please.
Is that seriously a radiocarbon fracture dislocation? Isn't the volar rim actually also dislocate the whole distal radius?
Yeah, so it's probably this part here.
Yeah, so I would not say that's a fracture dislocation.
So I would reserve that. Yeah, it seems like, you know.
It looks
basically
like a very distal
very distal.
injury. Yeah.
So,
That's
you
kind
know,
of my
earlier this morning, if any one of you attended Professor Bain's masterclass, he spoke about osteoligamentous attachment of the wrist. So he showed a similar kind of case. So if any one of you there, somewhat.
but I agree that the volar plate probably that kind of plate. I don't know how to fit
Okay.
it in again.
But then I know the plate's there for a purpose, and I think we know what it is.
Yep. Yes, tell me.
One question. So, what is the semi-skilled worker like?
So he does need to operate heavy machinery occasionally. Okay, but he is not the one who just has to lift load from one side to another.
Yes, sir.
Okay, yeah.
So I had one similar case where the cartilage, it is like a very thin osteochondral fragment, but then it's a whole wafer of the distal radius
Awesome.
that is gone behind. So I'm just imagining what must be the mechanism of injury in a laborer be to like sustain such a typical fracture of a whole.
Yeah, he fell from height. He was not at work. He fell from height where he was hiking. Maybe. Okay, so
Sorry, I just want to add something.
yeah, please go ahead.
But in order, I think, Zirin
Yeah.
here from Singapore. I've personally find that in order for us to really assess the distal radius fracture properly is to do a traction view. Like, if you should actually do a traction view and do an X-ray again, then you can really see whether the fragment is actually from the radial styloid or you're actually involving the volar rim. In addition to that, I would personally perform a CT scan to really assess maybe hopefully with carpal subtraction, so you really can see the intra-articular configuration. And maybe that's why from multiple images or additional studies, that's probably the reason why we decided to have a volar plate as well as a dorsal plate in addition to that.
Okay. So yeah, so the key points here are don't hurry through fixation, reduce this in emergency. Yeah.
So normally I'm not a big fan of external fixators at all, but very rarely they're still in my inventory. Very rarely when I get something like this and I really wanted, I would go back to the basics of span, scan and plan. So this is probably, I've never done it in the distal, very rarely, but some situations like this, that might not be a bad idea. You put an X-fix, get the carpus reduced, you're taking care of the dislocation, but obviously it's very unstable. So if you want to get a CT as well, put an X-fix, send them for the CT, you get all the information you want. Otherwise, like you said, I would very much take on your view of a traction view, but then if you wanted to get an additional CT, the moment no cast is going to be holding this, but if you put it on an X-fix and then, you have the information you need, and then you can come back and plan your battle in such a way that you have all the inventory and you have a clear thought process instead of trying to get through this in the emergency, and then these are the ones that come back to bite you.
So let me just, I think that's a very valid point. Why don't you tell us more about how you do your traction films?
Well, I mean, in the emergency department, I would actually attempt reduction. Obviously, it's very unstable, but I'll probably put a dorsal slab with a slight flexion. And we have an emergency CT scan in the emergency department. So with that, we can actually quickly do it. It might collapse again, but it does give us some rough idea as to like how the fragment is. But I would do a reduction, traction, and probably slight flexion, because in this case, just slight flexion and just do a CT scan in emergency setting.
Giving a hematoma block.
Yes, that's right.
You're going to do a CT. Right. So here's the thing. If you look at some of the published data in the JBJS about 12 years ago, they compared in resource-poor environments the utility of a traction film and compared it to the data in terms of fragment geometry from the CT scan. And it surprisingly matches the fragment geometry in the CT scan. And how we do that is just what Kiran said and what Zirin said. In our hospital, if you're going to do that, we give them a hematoma block. But before you do a hematoma block, you get a thorough neuro exam, because this person almost certainly has median nerve dysfunction, and you want to know what it is before you numb them up. And then you put them in finger traps. This is one of the very rare occasions I'll use finger traps. Hang them up and get a traction film. And if you have the access to a CT, then get a CT.
Yes, please.
About the X-fix, I agree. I don't need really much X-fixes or bridge plates, but actually this one would be great place for bridging plate. Even in US, they maybe use too much nowadays, but I think this is a perfect place.
So a few things that we gather from here. One, importance of traction view, get a CT scan so that you know what inventory to keep. Keep a span plate ready, and or X-fix if you are used to X-fix. We will come to about what is holding what later on. Meanwhile, Chaitanya will take you through his work on radiocarpal dislocations. Okay.
So one of the things that we learned about this is, now I agree that the radiographs are reasonably nebulous, but let's presume we've done the traction films, we've done the CT scan, and we've come to the conclusion that it's a radiocarpal dislocation, much like this one. And the fracture geometry is fairly predictable. Concurrent injuries are very common. Open injuries are very common, about 7%. And neurovascular injuries are very common. Ipsilateral monomelic polytrauma is also very common, because most of these injuries are caused by a mechanism where the elbow is stable and the wrist gets trapped, and it's an axial loading in that manner. So that's what leads to this injury. So what you're going to see is the fracture geometry is reliable, predictable, and consistent. Much like Greg said before, it's always the same, exactly the same. The only thing different is the size of the fragments. So there's always a volar lip, there's always a radial styloid, and there's always a dorsal rim. It's every time. And it depends whether it's a Dumontier type 1 or a type 2, whether it's a bony injury or it's a ligamentous injury. That's all that matters. Now, this is a case from about 20 odd years ago. You'll see that the devices that we used are much bigger. Small fragments equal to small implants, but you still use big ones. And we use suture anchors, and you can get a reasonable outcome.
So this is exactly what the volar and the dorsal plates were doing. They were trying to buttress those tiny fragments. But yes, it could have looked much less metal heavy than what it looked on the X-ray. And possibly, yes, yes, and yes, maybe I think a lot depends on the mental preparation of the surgeon. If I did go with the idea the way Chaitanya would have gone, okay, this requires minimal implants, knowing that beforehand, having that knowledge really matters. So you learn through experience.
I'm sorry not to make fun of you, but you said heavy metal. I just got cracked up about heavy metal.
Can I ask a question?
I said
yes, please.
Would any one of you guys fix the ulnar styloid? Because I've heard some opinions that in this injury that is so unstable, fixing the ulnar styloid also helps with the stability. What do you guys think?
So, okay. Let Chaitanya have the last word. I'll speak before him. So, a lot depends upon how I'm going to treat this patient post-operatively, and a lot depends upon what happens after I fix the distal radius fracture. If the DRUJ is well reduced, with a styloid fragment which has fallen in place, even if it was unstable to ballotment and I know I'm going to immobilize this patient for his other injuries, I would probably not bother fixing it. But if I wanted to mobilize this patient sooner, depending on the patient profile and depending on what the other injuries are, then I would go ahead and fix it and get them out of a plaster cast sooner. They still go in a splint. If the DRUJ is dislocated or unstable or subluxated, then I would probably try to put it back in its place and then fix the styloid. I wouldn't try to reduce it in a plaster and immobilize it. That. Yeah.
So yeah, the ulnar styloid fracture fixation is something that we perseverate about a lot, and I honestly don't. I haven't. In the last 30 years, I must have fixed 3 ulnar styloids at the most, and I don't do ballotment, and I'll tell you why. Let's if you don't mind, I'll show it on someone. So ballotment consists of that. That is an unphysiologic force. There's nothing in life that you do after fixing a radius that leads to this. So why are we testing it like this? This joint is functional when it does this. Why on God's green earth do we test it like this? Makes absolutely no sense to me. So I simply test it like this and feel it with my palms. There is a certain amount of translation when you rotate the radius around the ulna. It's not only rotation, but it's also translation. And I compare it to the other side, change my gloves and compare it. And if it's the same, which it almost seems to be, and the critical features are, did you restore joint reaction forces? And if you did, the ulna's not going anywhere. Secondly, did you get a left back? And this is what we don't talk about, the distal oblique bundle of the intraosseous ligament. If you got the distal oblique bundle of the intraosseous ligament back to left, that ulna's not going anywhere. So, like I said, 2, maybe 3 ulnar styloids in the last 30 years. Maybe I'm missing them. Yeah. Did you fix those? The ones that I fixed. So one was a Galeazzi, and so that was, it's a different animal. The second one, as luck would have it, was a physician whose, when I finished fixing the radius, I just could not get stability, and I realized later that the entire volar portion of the soft tissues was just shredded completely, and they just wouldn't stay there. So going back to my point about the distal oblique ligament, it was just gone. So I merely put it back at neutral and pinned it. 6 weeks later, he was fine, and he's back to practicing medicine. So.
Yeah, so I think the keep. Yeah, so, go ahead, Kiran, go ahead.
Hearing this, index surgeon would have handled this case differently?
Sorry?
Hearing all this discussion.
No, I don't think so. The index surgeon is pretty rigid with his thoughts. Okay. So here is the thing.
So we know it's a he.
You know it's a he, yeah. Here is the thing. The key point is comparison with the opposite side. And I did ask this question to one very famous hand and wrist surgeon. Is this test overrated, the ballotment? The answer was, what other option do you have to evaluate unstable DRUJ intraoperatively? One thing is what you said just now.
How about you test it functional functional
Yeah,
performance.
understood. Yeah, yeah. So this is one new learning point for me, that instead of ballotting, okay, you rotate and see, which we do, but perhaps we don't pick up the translation that you talked
And
about.
you don't pick it up because you rotate by holding the hand, which
Okay.
leads to intercarpal motion. The key is holding the forearm at the wrist, at the DRUG, and holding it at the base of your palms, which it feels very well. You hold it with the fingertips, you will overrate it.
So Chaitanya is letting out all trade secrets now.
Also, always, drape all your distal radius fractures all the way up to
Oh, unquestionably, unquestionably.
Perfect, yeah. Rohan.
In regards to the small molar lip fractures that go back, so there was a metal on the molar side. I'm assuming you have passed threads through the fragments and then through the plate. Has anyone tried using just anchors, like 3 or 4 anchors on the volar lip, and get this down and not use a plate at all? Is it stable enough?
Yes. Yeah, you saw in the case that I showed, there's a bunch of anchors, right? So if it was a Dumontier type 2, where you have the pure ligamentous injury, you have nothing else. So you have to support it with anchors and bring it back. And then in this day and age, I would put a span plate across that one. Simply because I would not be, in the old days, we used to put X fixes on those because you wanted to support your construct. A cast is not good enough, in my opinion, to support that construct, because there will be on a translocation of your corpus, which, like I said, is the kiss of death. So in this case, if you have a soft tissue injury, I would span it.
I also feel anchors are great if you have a reasonably intact cortex. So you have enough confidence in its pull out. The moment you put through a cancellous window, then I always have a lot of doubt about when they are going to pull out.
I think Rohan's question was, would you trust anchors alone as a fixation device, or you would add a secondary neutralization, be it an X-fix or a plate or whatever? Is that the question?
I would never leave it at anchors alone.
Same.
Yeah,
I think, never say never and never say always.
I know. But I still end up saying that.
I would prefer to.
The reason I say that is, what you say impacts people in different parts of the world, right? So if you're in a resource-limited environment and all you have is suture, you can fix this effectively with 26 or 24 gauge wire or number 2 ethibond, on 0 ethibond. You pass it through a short radial herniated ligament, make 2 holes in the distal radius, use a curved needle, and you make a figure of 8, and it's a tension band suddenly. It is that easy. You don't need to be a rocket scientist to do this. And then if you feel that, okay, that's all you got, fine. And you haven't got anything else, put a cast on it. Otherwise, almost any hospital in the world will have a plate. Or you can put a radiocarpal creva. I'm not a big fan of it, but yes, you can do that also. Yeah.
Yeah. Okay. And any other comment on the case that was discussed? Okay. Anybody wants to put a closing remark on the case, earlier case? No. Okay. Who wants to take a look at this? Yeah, Kiran, go ahead.
Intra-articular fracture, especially the scaphoid fossa, and there is a small flake seen on the PA film in the DRUZ. Now the teardrop is also not well seen.
Okay.
I'll get a CT scan of this wrist.
Anybody has any other view? So, CT scan? Okay, it wasn't done. This is what was done.
This
Done
is what
by
was
the
not done.
Sorry?
This is what was not done.
Not done.
Okay.
And the index surgeon in this case is not the same index surgeon as the last case.
I honestly don't think we care.
So this was at around 3 weeks. So at 3 weeks, when you see this, what would be your thoughts? Tina?
Oh no. Okay, so this is a very distal volar rim fracture.
Uh-huh.
I mean, the primary distraction forces, or rather distracting forces or displacing forces, is volar. So what my thoughts are is that because it's 3 weeks, right, and no CT scan, so if you add on a CT scan, it'll take another, in my institution at least, it'll take another week at least. before we get to the patient. So by then, all these scarring and all that will have set into place.
Wait,
we are
it'll take 1 week more to get a CT?
Yes.
Wow.
Yeah.
It
maybe
takes us
5
20
days.
minutes. So, sorry.
Yeah, so I think this one you require a very distal rim plate to reduce the fracture, the fracture subluxation of the carpus. But in addition to that, you might need something to handle the dorsal aspect as well.
Okay. What injury you are expecting on the dorsal aspect?
Oh, ligamentous, maybe some small rim fractures as well, avulsion fractures.
Okay. Jinzi, you agree with her?
Yes, I'm deep in thought because I still have no answer for this.
Okay. Ravi?
Yeah, I mean, CT scan.
Yeah,
obviously.
she said volar rim plate for the small
volar limb plate,
fragment and then...
I'm a little bit concerned about that, but this be soft sort of callus still should be able to get a reduction. And then once you get a, I mean, that at 3 weeks, once we get the correction and, I wouldn't be tempted in that scenario to do anything dorsally, to the bone fragments.
Would your decision to do anything dorsal depend on, again, intraoperative ballotment or something?
After fixation, you mean?
No, I'm talking, I'm asking Tina.
Yeah, many might.
Or you have made up your mind looking at this, yes, something needs to be done on the dorsal.
On the dorsal, unlikely. But in the event that is still unstable, you see, because this one, the main distracting force is volar, right? So once you have the volar rim plate buttressing the fragment, the problem should be solved.
So intraoperatively, you would assess if the carpus is going dorsal or not, would you?
Yes. So the other important thing in this case is to restore the volar tilt of the distal radius, the distal fragment.
Kiran, you had something. Sorry, go ahead.
No, because if it were to be dorsally tilted, then your axis of force transmission is still dorsal, and then you may end up with the opposite problem happening.
Understood. Yeah.
Because of the cast in place, we can't see it clearly, but in a lateral view, in coronal plane, there is a shear in the center. The dorsal cortex seems to be intact. It's purely the volar rim and the scaphoid fossa fragment, looks like.
So most of our discussion at this point in time seems speculative, right? So we have a CT?
Anybody has any contrarian view to what is being said here? Yes, please.
Not contrary, I would place this also volar because it's pretty distal, the fracture, but again, distal, which plate for this again?
Yep. So, I mean, how would a dorsal bridge plate address the subluxation?
No. I would also treat volarly.
In addition. Okay. Yeah, Karan?
So, sir, I have dealt with such a fracture. It is very, very distal. And with these fractures presenting late, they have also median nerve symptoms. I have also seen that. So should I tell what my plan would be, sir? I would get a CT scan,
does it differ from what was discussed?
Yes, a little bit.
Yeah, go ahead. What is different?
So I'll take a full carpal tunnel approach, extending into the FCR, extended FCR, do a small little osteotomy to just reduce back the fragment. Put a volar rim plate very, very distal, and take bites from the suture and those 3 holes that are there in the distal.
So you agree to volar rim plate?
Volar rim plate, yes.
Okay, fine. Thank you.
Can I say one thing more?
Yeah, go ahead.
I think the new hook plates, like a Medartis has one that you can actually put the scaffold fossa.
Yes,
I think that would be a good option for that.
Perfect. So the very fragment specific plates which would hold the volar rim different fragments, which are anatomical plates. Okay. So this is what the surgeon did. Any comments? So let me just not keep. I'll just go through the remaining. So this is what the volar plate was doing even in the earlier case. Sutures to the, I think somebody mentioned it now, sutures to the rim plate and woven through. Yeah, and this is the final picture that we got. This is after removal of the external fixator. Okay. Yeah, Yeah, the styloid seems to have had healed, but maybe it's the view. Uh, Tina, you said about, does the lunate still look a little dorsal? Or maybe not?
Looks neutral in this case.
Neutral, yeah. The volar tilt is not so accurately reduced. If, yeah, is there any comment on this fixation?
I think it's an excellent outcome, actually.
Okay.
Personally, I may have added a few of the distal rows because
Okay.
I believe on the initial X-ray, the scaphoid fossa fragment was, sizable. Yes.
It could have accepted a couple of screws.
Yes, so like a rough screw to ensure the volar tilt is restored. Yeah, that's the only additional thing I would have done.
Chaitanya, you would like to say something, or you'd like to go with your experience sharing on this?
You know, I totally understand where you guys are coming from with the use of various plates, and I belong to a generation where we did not have the luxury of 65 million plates to choose from, so we had to rely on principles. And I would urge all of you to go back to those times, because I understand where you're coming from with the rim plate and the flying buttress and everything. But let's say something happens and the scrub tech drops all your plates on the floor. Now what are you going to do? And trust me, that's happened. You have to have a plan B, C, D, E, and F. And so having the ability to think on your feet and address it with small devices, alternate devices, is a good thing. I have associates, I have trainees who absolutely get panic struck because they don't have a specific plate. It's not the plate, it's the principle.
Could always contour a KY,
Oh yeah,
and
absolutely.
fashion a hook, put in a screw,
Yeah.
options are plenty.
So going back to where we were, for those of you who are still in training and who are here, these are the things that I emphasize to my trainees. I look at the teardrop angle. And why the teardrop angle? Because it is a surrogate for the intermediate column. I don't need to belabor this point. If your teardrop angle increases, then you have a displaced volar margin. Now this is one of our nurses in our hospital who was told that she had a small fracture and she should just go home and rest. Unfortunately, they missed the fact that her teardrop angle was very high. And she came to see me about 6 weeks later with this. So it's a completely displaced lunate facet, which is fairly small, and it's shaped like a boomerang. So the fracture patterns in this situation are varying sizes, and these are the various, I call them the boomerangs, which you can see either they're isolated or as part of the volar Barton, or they're shaped like a sliver that you see in a radiocarpal dislocation, or a club that you see in the intermediate column fractures. So if you wanted to look at some of these, there's some of these. I'm happy to share these with you guys. So
do we have time for one more case? Yeah.
is someone following us here?
I don't know.
Yeah.
Yeah. Yeah, so this was the similar teardrop missed case. Unfortunately, I don't have any index surgery X-rays of this patient. This was the X-ray and CT scan. This is 3 years post-fixation and a stiff wrist, young individual, young man. This is exactly the missed teardrop. And the carpus has toppled over the plate. So looking at the teardrop angle intraoperatively is very, very important, whether that angle has been restored or not. Who would want to do what for this patient? It's one of the rare occasions where the index surgeon has done a CT scan.
Okay, assuming this is a youngish patient who is symptomatic.
He's in his early 30s.
So we have actually 2 joints to address. One is the radiocarpal joint and one is the DRUJ. We cannot forget about DRUJ. Yep. It's obvious on the lunate fossa, the fracture has collapsed. Yeah, and that's why the carpal bones are all overlapping with the implant. So first, more detailed scans, like
Okay.
CT scan. Yes, yes. This is a very
Okay.
tough injury. So I think for the radial couple joint, you need like a RSL fusion. But what you would do to the ulnar side is the difficulty. Whether you want to shorten the ulnar or do some kind of hemi resection, or I think everyone will have different options. and
So you're
opinion.
considering salvage. You're not considering any reconstruction.
I think at 3 years,
Yep.
I don't think the joint is salvageable.
True.
Yeah.
Very true.
Yes, I would, but I wouldn't give the patient hope.
Okay. Yeah, if a cartilage was lying outside the joint, then the chances of condylolysis are real, and so are the chances after the lunate has been sitting on the plate. But if it was subluxated and still contained within the joint capsule, like maybe in this case, we probably can hope to have articular cartilage which is still getting nourished. Ravi, you would do anything different than what Jinji said?
Years, like I said, I wouldn't have too much of hope about the cartilage. But I personally had a situation where it's about 7 months, 6-7 months, where I've not done salvage. I've gone and done an osteotomy and still managed to get away with reasonable results for a similar kind of case. But 3 years, I wouldn't be very optimistic,
Yeah,
honestly.
so I do not know how many of you attended Dr. Warrior's case in the morning where he found a plate with a triangular screw.
Yeah.
So this was a gentleman he also had a similar plate. I opened it and I realized I don't have the screwdriver. I closed it, came back next morning, took him in the theater again, and then removed that plate. So I was completely caught off guard, not keeping the correct hardware ready. And this is the point I wanted to make on this case is the fragment is sitting in front of the plate. So it's truly not malunited, it's ununited. Okay. So, and would when you see this, would you still be tempted to do an RSL fusion, or you would be still tempted to put it back? The index surgeon was heavily tempted to put it back.
You have to examine the cartilage.
Okay.
Just make your decision based on what's there.
Okay. Okay. There was no arthroscopy performed, and the cartilage, once this fragment was lifted off, you could see some part of the lunate which did not have a very healthy cartilage. Okay. So that's the plate that was removed, and it could be put back to a reasonable anatomy. So, thought process, if this is stiff in this position, how is it not as good as an RSL fusion?
Because you still have the lunate, and then it can still be painful. An RSL fusion would not be painful, and the movement would be happening in the mid-carpal joint. We still don't know what if the lunate is damaged articular cartilage-wise. This could still go on to give him grief, although the X-ray looks very good.
Okay, so yeah, that was the plate. So the point here is probably the temptation to put back the articular fragment should be overridden by your concern for creating a painful joint, from a stiff joint to a painful joint. And if this patient was eventually headed for RSL fusion, you probably have just added one more surgery to his medical file. Yeah. You want to take this? Yeah.
So Neil Harness and Jesse Jupiter had published the first, I think, 6 cases about 20 odd years ago in patients over the age of 60 who had this kind of situation where the lunate facet had skipped the plate. And the conclusion was the patients who had revision surgery did the same as patients who had no revision surgery. So in a patient who's more than 60, for me personally, if they don't have symptoms and they have reasonable motion, it's perfectly reasonable to leave them alone. And your point is well taken about the quality of the cartilage and RSL fusion as a bailout. So, and the reason I wanted to show you this case is because of some this is an unusual fracture pattern. When you see this X-ray initially, you're tempted to think of it as a lunate facet fracture. Treated non-operatively, landed in my lap at about 3 weeks, and you get a CT scan and you see that it's the entire intermediate column that's been punched down. So it's very unusual. Again, Greg's described it in his book. So there it is. And these are the ones that I would approach through an extensile carpal tunnel approach. And I use this construct pretty frequently. And the one thing that I try to tell everyone is, if you want to look for the fracture site, this is where you find it. You put your finger along here, and you come to the irregularity, and then you lift it up from there and restore it. So, good. Are we good? It's about 4:05, and
We have 7 more cases lined up.
is there something starting at 4 o'clock someplace else?
If there's something important.
Yeah, no, the organizers will tell us they are here.
Yes. Yeah.
I'm just trying to correlate the polar rim fracture to anterior dislocation of the shoulder. It comes out with a little fleck of pieces, and arthroscopists put 3-4 anchors anteriorly, and such a big joint does very well with the anchors. So why are we so worried or about the wrist? Means can't we just put anchors and forget about it? Is there some
I
physiology?
think the analogy is reasonable up to a point, because the orientation of the joint is entirely different.
Okay.
So if you think about the way most people sit when you put them in a cast, they don't sit like this, right? They sit like this. So you have to think about the influence of gravity on the hand,
Okay.
and that's where the problem lies. So.
And it also is probably related to the amount of soft tissue that is available in the shoulder for the ankles to hold back onto the anterior surface of the glenoid on the rim. Here, if you see the volar avulsions, they are practically devoid of anything that is going on to the radius, except for the thin rim attachment. So there is probably not enough soft tissue area to heal to give you a stable joint. Is there anything in this hall?
No. We are free. We are good to go. I mean, unless someone wants to go to another hall, we are good to continue till 5. So we have
We will continue
an
until
hour.
the last man is sitting.
Standing for sitting. Or fallen.
We got to be gender appropriate. The last person.
Last, yeah. Man was a generic term. It was for the human. The index surgeon did not do a CT scan. Okay, go ahead.
Open or closed?
This was a closed injury. She did not have any neurological. Oops.
Elderly patient?
She is in her mid-50s.
Again, the hematoma block, traction views first.
Yeah.
Give an appropriate, possibly dorsal slab, and then reassess with the traction view X-rays. If CT is not available, at least the traction views, and then
Yeah. So one thing
possibly
that is coming up repeatedly is getting a good traction view for all comminuted fractures. So even if you don't have immediate access to a CT scan, we can always have access to a good traction view, which was not done. Yeah, tell me.
So what's the first thing you think about when you see a distal radius fracture X-ray? What goes on in your mind? Are you going to think of how you're going to fix it, or are you going to think about what's going on here? And then, is there all the information that I need to have already there? And then maybe you start thinking, what are the sort of, components of the fracture, if I may? You might not need to classify it in any elaborate classification system, but at least you have a thought process in mind as to, what are the components individual, and, how you're going to address them. So that's the point. I mean, to all of us, I just want to know, do you follow any rigid classification system when you see any fracture, or you just know what to do? Or
Yeah, we can fill that to the rest of the panelists.
what first question I come to my mind is whether it's open or closed. Is there any neurological injury associated with?
Yeah.
What's the neurovascular status of the hand and the wrist?
No, that's not
And-
what Ravi meant. What Ravi said is you
start thinking, is it an AO?
this is your patient. You have been called to see this patient. What is your thought process that goes when your patient is in front of you, the X-ray is in front of you? Now what? You already have the information that you just now asked for.
Right.
Okay.
No, so no particular classification system comes to my mind. I'll treat it symptomatic first, stabilize the wrist, edema control, and then go in a planned manner or other with a good planned armamentarium. I'll take a good break of 2 to 3 days for the edema to settle down, and then plan a definitive surgery.
Okay. Tina?
Okay, this is looks like a high velocity injury. Right.
This unfortunately, fortunately it wasn't, but yeah, it was a fall, but probably it was a very bad fall.
Very bad fall.
Yeah.
So in these instances, I already expect significant comminution of the fracture, articular involvement and all that. I think it goes beyond the AO classification. That's more appropriate for fragility fractures, for example.
Yeah.
Right. So this one we anticipate a very smashed fracture. And probably very osteoporotic as well, if a low velocity fall can result in this kind of injury. Yeah. So that's, I don't follow a specific classification, if that's the main question.
I'm very happy you did not say CT scan. So the reason I keep talking about CT scan is, you send the patient for a CT scan with certain things in your mind. This is what I want to see, and most often the CT scan does not, the films do not come with the information that you want. And very rarely I find that you have any additional information on the CT scan which will change my treatment plan. And therefore I'm more and more averse to CT scans. And even my friend who is the index surgeon is also very averse to the CT scans. So, Jinzi.
Yeah, actually, when I see this X-ray, the first thought that comes to my mind is, what does the patient need her hands for? Because, like you said, it's a low velocity injury. Patient doesn't sound so young. I think you mentioned she's 50.
Mid-50s.
Yeah. So actually, when I treat distal radius fractures, my main concern is, what does this patient need their hands for?
Okay.
Then I decide what to do.
So yeah. Who else? Yeah, sorry. Just shout out, okay? Sometimes I forget to look on this side.
I actually love CTs, especially nowadays when we have CBCT, which is the radiation is the same than from native X-rays. So I actually nowadays say, why we even take any more native X-rays? We should just take CBCT's exam. And I can't understand people who say, oh, I don't understand the same things from CT that I understand from the native X-rays. I mean, we have to get to the level that we understand the same things from CT than from X-ray.
Perfect. I agree. I think there is a bit of a learning curve for that. Okay. So here's the thing. I'm not senior enough to say in my experience or something. That's for Chaitanya. So over a period of time, I have actually, I very, very rarely do a CT scan for distal radius fractures, and I've learned that if you stare hard enough at the X-ray, you have all the information that you need most often. When I look at the X-ray like this in casualty, first I think, what mechanism would have caused this and how I'm going to reverse it. So will this fracture I'll come back to you. So once I reduce this fracture, is it going to stay reduced or not? If I know I'm going to require fixation for this, then I start thinking what type of fixation I'm going to need. Will I need dorsal plates? Will I need rodal plates? Should I keep an external fixator ready? So that's what goes on in my mind. I do not look at the radius X-ray and say, okay, plating. No. What mechanism and how am I going to reverse it? Sometimes a bad looking fracture, and I realize that if I just put it in a good plaster and I can hold on to that reduction for 3 weeks, that I will sail through. So despite my first temptation to surgically intervene, I said, look, let's give it a try. If it stays in place for a couple of weeks, we'll probably not need surgery for this. Not sure if CT scan helps me making those decisions, really. Chaitanya? Yeah, please. Chaitanya, then Karan, and then you. Yeah.
So when I teach my trainees about this, I usually say that if someone sends me a set of radiographs like this, and I'm wandering down to the ED, and I haven't done that in a while, but I call them elevator thoughts. What am I thinking about when I'm riding down or up in the elevator? What I'm thinking about is, almost certainly this thing's got to be open. Maybe puncture open, maybe flagrantly open. Number two, what's the status of the median nerve? Number three, more importantly, the status of the ulnar nerve, because we pay attention very less to that one. And why do I say that? This is post-traumatic manus valgus. And post-traumatic manus valgus is the largest reason for underdiagnosed or undiagnosed ulnar neuropathy. And we don't pay attention because you can't get people to cross their fingers or examine the first dorsal interosseous. So it's very hard to diagnose it. So we don't pay attention to it. Median nerve, everyone pays attention to. Oh, my fingers are numb, I can test the thumb, but no one looks at the ulnar nerve. Most underdiagnosed. So those are my elevator thoughts. When I get down to the ED, I obviously look for any open wounds and all that. But the more important thing in this person is, I'm going to look at the elbow. Because if a small fall could do this to the wrist, what else did it do? So I'm going to look at the elbow and the shoulder very closely. And then, of course, for me, I'm not smart enough to make decisions on a plain radiograph, so I would get a CT and then take it from there.
CT post reduction, temporary reduction.
Yes, so in the ED for us, we have a mini C-arm. So it's very hard to get hematoma block when fractures are this displaced. But get a good neuro exam, get a hematoma block, and if you can get conscious sedation, we do conscious sedation. And then get a traction film, get a sense of what the fracture's at, splint it, and then get a CT.
So this is my argument to getting a CT, and this is where I will differ from Pankaj. All of you seen the movie Top Gun Maverick, the sequel? You know the movie, you've not seen it, Tom Cruise, it's an iconic movie, have to say it, okay. So there's a comparison which he makes. So he flies an F-16 Tomcat, and he goes against the 5th generation stealth fighters, and he said, there's no way you can. But he says, it's not about the technology of the aircraft, it's about knowing the potential and what your aircraft can do. And he very, dramatically throws away the aircraft manual and says, what is the best performance your aircraft can do for you? So it's about knowing your implant inventory. So you have a volar locking plate, which is a variable angle, which is your F-16 Tomcat. Okay, you might not have hook plates and all those fancy inventories with the 5th generation plates, if I may put it so. So what you have is your inventory, which is available to you. How do you use the plate to maximize your fixation? It's not about just diagnosing and picking up the fragments. It's about giving the best outcome also. So here is where a CT will help you. Your axial cuts will tell you exactly. So because a two-dimensional, X-ray can never compare to the benefit. If you know, obviously if you're looking at the 3D CT scan, I throw them out of the window. I don't. That's just to impress the family and tell them, okay, you got a very smashed up wrist, that needs surgery. Okay, I need to convince them to get the surgery. But actually, if you're using the plate to its full potential, you have a fracture fragment, you want your screw bang in the center. And that's where the variable angle feature helps you to tilt the screw in whichever direction trajectory. It's a cone. And that's where, preferably get 2 screws in each of the major fragments. And I think a CT is great, you see, that's why we moved away from the fixed angle, and I've written a chapter in this book of implantology. That's why we moved away from the fixed angle, plates to the variable angle. And if we have a variable angle plate and we don't use the plate to its full potential to give you the best benefit and the outcome, it's like having an iPhone with all the fancy features, you're still making old-fashioned phone calls and not using all the features.
I'm going to put a question to everyone, including Chaitanya at this end and Dr. Warrior at the other end. So how often do you land up using the variable angle feature of the variable angle plates? I will start by saying I almost never, I did not say never, almost never land up using the variable angle feature. I use a variable angle plate because I like the 2-column design of that plate, but I almost land up using all screws in a fixed angle.
Okay.
So
I almost always use the
variable angle plates.
Do you use the jig?
I use the jig.
So you screw on the jig and then just shoot the.
Yes.
I tend to do the freehand, and I think I'm using the variable angle feature of it.
So you use the variable angle feature to an advantage that you don't need to use the sleeves because then the free hand will also give you a
Yeah, there's a caveat. So the variable angle jig allows you to move the screw in a 15-degree cone. I also stopped using the jig. Yeah, it does. Yeah. Not the cone.
Not the cone.
Okay, the fixed angle. Oh, you do it freehand. Yeah.
He's talking about a guide block.
The guide block. Okay, yeah. The only thing, if you do it freehand, I had one case with the flexor tendon rupture. So, you have to make sure that the screws lock in and there's no prominence of the screw. If it's even slightly offset, that fraction of a millimeter screw, which is sort of, a little bit proud, maybe 2 years down the line will come back to bite you. So you make a point to run your finger on the edge of the plate to make sure none of the screw heads are catching anywhere. Even if it's a fraction of a millimeter offset, you won't be able to see it, but your finger will be able to feel it.
Yeah, this discussion to me, are you familiar with the Greek term, Latin term, quod erat demonstrandum, QED? We use it in geometry, right? What was to be proven? And this discussion just highlighted exactly what I said 20 minutes ago. As we are so hung up on plates and their features that we forget why we are doing it in the first place. And the principle is subchondral support. How you get the subchondral support doesn't matter, but you got to get the subchondral support. Whether you use the 30-degree cone that Ravi talked about, whether you use the screw-in thing that Sudhir talked about, or Pankaj says, that he's going to do this. The point is all of them are trying to do one thing, and that one thing is subchondral support. So.
Does the velocity of fall support that much of communication in this particular case?
So I used to use the word velocity, but I use energy. Because let's take someone who is Tina's size. If Tina were to walk on this carpet or on the floor and fall from that height, I'm reasonably confident that her age, she won't get that fracture. But let's take someone who's 5 times Tina's size.
Me.
Okay. But if you were to do the same thing and fall, the energy of that fall will be entirely different, right? It's F is equal to ma, right? And that's my point. So if you in answer to your question, depends what the size and the BMI was of that person who fell.
I would love to know that, because in my experience I am finding many people with hormonal imbalance known to be the cause of massive crush because of trivial fall.
Yeah. Keep metabolic in mind.
Yes.
Yeah, go ahead. You have a question?
No, I want to add one question.
Yeah.
Could you put the X-ray back? Like, so this particular fracture pattern is different in the sense it has a distal ulna also, and it has an oblique fracture.
Yes.
So whenever this is a fracture and low velocity injury, I think it is a staircase fall, sir, in a mid-age of a lady.
Yeah, possibly, but I don't recollect what she told the index surgeon. So,
Right, sir. So, secondly, sir, your point that before sending to CT scan, so this X-ray, I think it has been taken without a slab, and the lateral view probably is not there because it must be painful, sir.
Correct.
So, I would first try to put it back in a dorsal slab, and then get a computer film of an X-ray,
Correct.
and then to analyze, I work at a place where we are forced to analyze what you are trying to see at a CT scan.
Understood. So point you are trying to make is this no matter what the comminution or situation, try to get proper PA and lateral X-rays and
Yes, sir.
analyze them.
And
So
then it's sent to CT scan.
perfect.
So,
Yeah. Okay. So this was the situation after fixation of the radius. Fixation of the radius was quite uneventful. Okay. And this was the situation of the ulna. How often would you fix this ulna if you saw this situation intra-op? Jinzi, then Tina, then Kiran, and then...
Jinsey, I will fix it 100% of the time if it looks like this.
Okay.
I agree with Jingxi, but recently, the past 1 or 2 cases that I've done, if they're not so displaced, let's say it was not totally displaced like the original X-ray, right? It was just a undisplaced associated distal ulnar fracture. Then what I do is I range I do it under fluoroscopy after fixation of the distal radius fracture. If the patient's distal ulnar does not move at all, then I don't fix it. And they turn out fine, actually. They're very happy because I think most times when we fix the distal ulnar fractures, we tend to require removal of implants, and a lot of our elderly patients are very fearful for some reason for undergoing the knife again. Yeah. So
Kiran, would you fix if you see this situation?
This seems to be unstable, so I'll consider fixation.
Okay, and stability or the location of the fracture is what is bothering you?
It's the stability, because location of fracture wise, the distal radial ulnar joint seems to be in place with the radial height bed getting restored. But it's a metaphyseal area. There is a possible radial spike of the proximal fragment of the ulna, which is not getting aligned, and there is a ulnar displacement. So there is a possible proximal migration of the distal fragment, which may happen over the time because of the metaphyseal weak cancellous bone.
Okay.
So getting a better height restoration of the distal ulna will make you comfortable in early mobilization of the wrist.
Ravi?
I would fix it, but these kind of fractures, I don't tend to fix them with open reduction and plates. I would probably put a couple of K-wires.
Okay. But you would fix probably.
I would fix.
Chaitanya,
Sudhir sir, I would like to know your thoughts also.
Forget about this case. A comminuted distal radius fracture with associated metaphyseal fracture of the ulna. We are not talking about the styloid fractures. How often you'll end up fixing them, or what is it that you base your decision on?
So, as I've gotten older, the use of age as a determinative tool has become less important to me. So, but jokes aside, if it's a young person who's, say, under the age of 45, 50, 55, and they have a demanding position, then I may be inclined to fix it. But in patients over the age of 55 or 60, there's enough published evidence which shows that not fixing the ulna does not lead to any deterioration of outcome. Especially in patients over the age of 65, for sure, I probably won't fix it. The only reason to fix it, if there is loss of intraosseous space. If there is loss of intraosseous space, they will sacrifice rotation. And in that case, I would restore anatomy. But like Tina said, you have to caution them that hardware removal is going to be very likely. So.
Clinical evaluation of DRU is very important before making any decision of this patient.
So you know what, the fractures of this type, the silver lining is when the radius and the ulna have toppled together, the DRUJ is reasonably spared.
But sometimes it happens. The first thing if you do.
So I do not know if any one of you agrees with the statement that I made.
Yeah. But if the
Actually, I did not make this statement. The index surgeon made this statement.
So if you, majority of cases, if you maintain the distal radius anatomy reasonable, DRU becomes stable in the vacuum.
Are we done?
Yeah. So we just finish this.
Yeah.
It's almost.
Could I have Sudhir sir's thoughts on the other side of this case?
Yeah, this is what I did, but would you do this?
Just go back. Just a couple of points. Number one is when you restore the distal radius alignment, and if what you are saying is true, that means the DRU and the PRU, or the DRL and the PRL are intact with the ulnar styloid, it should fall back in place. Better than what this is. This is translated and collapsed a bit, which means the height of the radius is probably not fully restored. And if standing from here, I feel that the radius is also slightly tilted towards the ulnar side. If that was corrected, and if the height of the radius was corrected, I think this styloid would have fallen into place, and maybe then I wouldn't fix it. But in this situation, I would fix it so that the interosseous space then tends to open out a little better.
Yeah, the take-home, sorry.
He's shown what he's done, and that looks good.
So the take-home point,
I'm not going to argue.
point is for most of these fractures, the patients would do quite well leaving the ulna alone as long as it has just gone back to its place. And if it has not gone back to its place, the reason is somewhere in the radius and not on the ulna side. Okay.
Great.
Yeah, she's done well. Thank you everyone. I hope I hope we made your this was worth your time. Thank you very much.